Well, good afternoon, everyone, and welcome back to the Regional Rounds hosted by the Regional Geriatric Program of Eastern Ontario. Once again, my name is Matt Sekeli, and I'm a manager of education, knowledge, translation, and research here at the RGPO. It's my pleasure to be your host again today for these great rounds. As I mentioned at our last rounds, we're thrilled to host these rounds again. We hope this is an opportunity for all of you to learn, collaborate, and network with all of your colleagues across geriatrics. Before we start, I'd like to acknowledge that the Ottawa Hospital, where we're hosting these rounds today, is located on the traditional and unceded territory of the Algonquin people and respects the traditional knowledge and healing development over generations. We have the privilege and responsibility to serve First Nations, Métis, and Inuit of many backgrounds and from many treaty and non-treaty lands, territories, and to demonstrate respect for the contributions and cultures of Indigenous people. We're pleased and honored to work and teach from these lands. So for today's session, we welcome Dr. Sujin Chan from the Royal, who's going to be speaking about inappropriate sexual behaviors in dementia. We're great to have Dr. Chan, who's a geriatric psychiatrist from the Royal Ottawa Mental Health Centre. She's the postgraduate site educator director at the Royal for the University of Ottawa Psychiatric Resident Training Program and the Geriatric Psychiatric Subspecialty Program. Previously, she has served as the Director of Education for the Division of Geriatric Psychiatry as well at the University of Ottawa. Dr. Chan is locally trained here, doing her psychiatric and subspecialty training in geriatric psychiatry at the University of Ottawa, and her clinical interests involve providing clinical care to geriatric patients, primary outpatient and nursing home settings. Currently, she is the clinical lead for a city outreach program at the Royal as well. On top of that, she's also very well published in numerous papers in geriatric psychiatry, as well as education and clinical care. And she's active in teaching residents and medical students at the University of Ottawa, for which she's won many, many awards. And on top of this, she has two twin boys, and so she's very busy with that. And myself being a father of two boys, I know how busy that is. So we're great to steal her away for an hour for this talk. So please welcome me in join me in welcoming Dr. Chan.
Hello, everyone, and Matt, thank you for the nice introductions. So for those of you who are on Zoom, I don't see you, but I know you're there. So if you have any question, I encourage you to put it on the chat and we have a way to address it at the end. So, and thank you for joining me in person in this beautiful Tuesday, wonderful weather outside. But thank you for making decision to spend your lunch hour with me today. So yes, I'm Dr. Sujin Chan. I'm a geriatric psychiatrist, and I'm going to talk to you about inappropriate sexual behavior in dementia today. So no conflict of interest. So here are the learning objectives. So before we go into inappropriate sexual behavior, sometimes I'm going to just refer it as ISB. I'm going to first talk about, I'm going to just wait a minute for people. So please come in. Yeah, come on in. Yeah. So the first part of my talk, I'm going to actually talk about sexuality in older people, something that we probably not really talk about, but I think it's a really important topic to go through before we move on to inappropriate sexual behavior. We're going to talk about some of the common misconceptions in sexuality in older people. Then we'll dive into inappropriate sexual behavior. So I'm going to talk about epidemiology, some boring stuff like the brain structure and stuff like etiology, and then we'll go into how we assess these patients and also how to manage them. And I'm going to talk about some medication options as well. So people are living longer and healthier life, and sexuality is one of those important things that we do have to talk about whether you like it or not. So all individuals, regardless of their age, their cultural background, the medical conditions, we need love, touch, companionship, and intimacy. However, sexuality in older people are largely neglected topic. Healthcare providers should look past societal stereotypes of elderly people as asexual being, which is one of the biggest misconceptions that we have. Care must be taken not to pathologize appropriate sexual behavior in older people. So sexual expression actually contribute to many of the positive things. So it contribute to overall health, prolonged longevity, maintenance of a healthy relationship, and overall the sense of well-being and quality of life. Sex also has shown to reduce loneliness, fear, and anxiety and boredom in older people. So of course, so it sounds like a really important topic to talk about for sure. I mean, the question is, why are we not talking about it, right? So here are a long list of negative misconceptions. I'm not going to read through all these, the list, but I want you to kind of go through them and kind of think like, okay, I have that. I used to, not anymore. So, have the mental exercise on your own. And I have to say that, growing up in an Asian culture, I think I probably had all of these in my mind at some point. And I'm really trying to understand myself and trying to educate myself because it is important to realize what types and what kind of misconception we have. So I thought that I'm going to do is to address some of them in more of the question and answer kind of a type. So are older people interested in sex? They sure are. So the study out of the University of Michigan, so American Association of Retired Persons Healthy Aging poll. Okay, so it's from 2018. So they surveyed people between age 65 and 80. And about 2/3, so this is about 66% said they are interested in sex. And of those, more than 50% said sex was important to their quality of life. So if they are interested in sex, sorry for those who are just walking in. So I'm just trying to say, so we're just talking about, so people are interested in sex, older people, but doesn't mean that are they sexually active? Do they have sex? They sure do. So the frequency of sexual activity decreases with aging. When you kind of think about all the medical conditions, that mobility issue, it kind of makes sense, right? But majority of older people actually continues to be sexually active. So I'm going to talk to you about two main studies today. So the first one, they surveyed over 3,000 people. This is out of the state, so National Social Life, Health and Aging Project. So what the pattern that you see here is that as you go to the older age, the prevalence of people who are sexually active, it goes down. But when you look at the people between 75 and 85, according to the study Lindu et al., more than quarter of them, so 26% of them are sexually active. And I don't know if that surprised you, but more than 1 out of 4, okay? And of those people, more than 50% of them had sex more than 2 times per month. The second study is out of UK. So Lee et al. 2016, English longitudinal study of aging. So again, we see the same pattern. So within the geriatric population, as they get older, the prevalence of people who are sexually active goes down. But even when you look at older geriatric groups, so 80 plus, 30% of men and 14% men are sexually active. And this is a common pattern. So if for each age group, more men are sexually active compared to women, okay? So what predicts sexual activity in older people? Male gender, as I just mentioned, availability, interest, and health of partner, because many of them lose their partners in older age. Individuals' physical and mental health, so their own physical mental health, and also their partners' physical and mental health. Previous level of sexual activity and interest, that's really important to kind of understand what is their baseline sexual activity like. For women, quality of the relationship is the most important factor. For men, physical health is the most important factor. So there's some discrepancy there. So moving on to the next misconception, next question. So what do you really mean by sex, really? Okay. So I think we have this traditional way of thinking that sex is, with men and women, partners intercourse. But in reality, that's not really true, not just for the older people, but for younger population as well. We also have to think about the LGBTQ population as well, right? So older people need to adopt their sexual activity due to their physical condition or mental health status. So think about people who have arthritis, chronic pain, neurological condition, mobility issues, so they can't really move much. Maybe people with erectile dysfunction or vaginal dryness. All these things combined, people might need to adopt what it means to have sex, right? So this kind of broaden that definition of what we mean by sexual activity. We talked about how some of them might not have partners, so they can't really have a partner's intercourse when they want to. So need to consider different forms of sexual activity as beyond the penetration sex, including oral sex, kissing, fondling, solo sex, what we refer as masturbation more commonly in the conversation. Okay. I don't know if I'm making some of you uncomfortable already, but hopefully not too much. Okay. Okay, next topic. Are older adults at risk of STD? For sure, for sure. So I mentioned about how these population, are living longer life, healthier life. So this assumption about how older people are not at risk of having STD leads to lack of conversation about STD and sexual health overall. So what I want to tell you is that rate of STD among older people has consistently increased and doubled over the past decade. So according to U.S. Center for Disease Control and Prevention, published in 2023, prevalence of gonorrhea, syphilis, chlamydia all went up last decade. So older generation, so the part of the issue is that older generation rarely think about using protection. Reasons being, for that generation, there's probably likely lack of sex education. HIV was not talked about. And for that particular generation, the main reason for protection was for avoiding pregnancy, right? So for those combined reasons, they don't often think about the reason to use protection. So STD also might be going up more further due to another reasons, such as availability of drugs for sexual dysfunction like Viagra, commonality of living in a retirement home community, and also increased use of dating apps for seniors. So there are dating apps just for specifically for the geriatric population. Okay, so if I'm telling you that this is so important, that why are we not talking about it? So there are many, many barriers that we face. And I think some of them are what we already talked about. So all these misconception about what sexuality means and what it is in older people. But I think it's sometimes the patient themselves don't feel comfortable, right? So they don't want to talk about it. They feel maybe ashamed and shy about it. And the other, the side of the coin is that we as a healthcare providers, we might feel very uncomfortable talking about it, or sometimes we don't want to offend them. And that's probably one of my first thought too, as a young female, resident and students, I didn't want to offend them. I didn't want to be rude. So maybe sometimes we don't talk about that. And the other thing that I want to talk about is in a very busy clinical setting, like all of you, just think about your day. And sometimes, even though I have 90 minutes for new consultation, I feel like I don't have time to talk about that. After going through all the list of things that I have to go through, I just don't feel like I have time to ask them about sex. So maybe I'm kind of avoiding that topic as well. So I think this is a really important topic. So I assume that some of you have worked in nursing home, have experience in working in nursing home. So sexually long-term care is one of the topics that we need to talk about more. So the interest in sex, right, for older people necessarily doesn't change when they're admitted to nursing home or when they move into retirement home. So it is really important that, the education is provided to staff and they are aware of a resident's right to sexual expression. And at the time of admission, of course, there's a sexual history taken, but it's also important that we do that regularly, so not just at the beginning when they're admitted to the nursing home, but as you go by, every so often, you should be taking the further history. Ensure adequate privacy for couples wishing to be intimate. So, those like do not disturb sign, or maybe you can use the lock on the door if that's safe, right? So you have to make sure that's a safe approach for that particular patient. So when you look at Alzheimer's Society of Canada website, there's actually tons of information about intimacy, sex, and dementia. So people with dementia can continue to have a healthy, intimate life, the sexual life with their partner for many years. However, dementia can change the way one expresses their sexual need, and sometimes they feel more anxious and fearful about, engaging in sexual activity or even expressing it. And some couples may end up discovering different ways of expressing their intimacy. So partner makes experience grief over the loss of simple acts of intimacy, what we call ambiguous loss. So ambiguous loss is when having the sense of grief when the person is still alive. And this is not uncommon in the couple with one of them is dementia. So in a situation where one of them has dementia, there might be some cases where both of them are looking for a new partner. So in a way that to look for that intimacy. So person with a dementia might not even recognize the own partner and might have some kind of close relationship or intimate relationship with someone at a nursing home, for example. It might be with the same gender or opposite gender. The partners may also they might miss that intimacy and they might start looking for new relationship outside of their marriage. And this again, I think we have certain misconception about this, but this is actually quite common. If you have experience working in nursing home, how the wife or a husband start looking for different relationship, and it's so important that we don't talk to them in a judgmental tone about that, right? So just a really briefly, but really important topic about supporting LGBTQ individuals in the dementia. So LGBTQ individuals may have a difficulty expressing themselves not only because of dementia, but because as a result of prejudice and discrimination they've experienced, probably, the big chunk of their life. Some of them actually, very unfortunately, feel that when they move into retirement home or nursing home, that they have to return to the closet because they don't feel safe to tell other people. So what can we do as a healthcare providers? First of all, examine, as I mentioned, your own personal value and beliefs regarding sexual orientation, gender identity, and how that can influence your care to other people. Ask what pronouns they want to use. I think we're getting better and better at doing this with the younger population, but same goes to older person who are LGBTQ as well. Learn about the resources in the community. And the next point I think is a really important one. Respect their wish if they don't want to disclose. So you don't just assume because that person told you that now you can go tell everyone in the staffing or other residents in the nursing home. So ask the person, what would you like to do and what's your wish? And then just respect that, right? Use gender neutral language, rather than saying husband, wife, use partners, significant others. Again, I think we're getting better at it, but I think we have room to improve for sure. So I just wanted to put two links that I found from the Alzheimer's Society of Canada. Again, I'm not an expert, but I think this is a really important topic that we need to educate ourselves. So here are some resources that I found for you. All right, so that was a quick overview of sexuality in older people. And now we are going to dive right into inappropriate sexual behavior. So again, sometimes I might say ISB, and that's what I'm referring to inappropriate sexual behavior. So, inappropriate sexual behavior. So, what is the definition? Well, there's no common consensus on appropriate definition of ISB. And this might really contribute to lack of research, unfortunately. And what is considered appropriate versus inappropriate may be influenced by cultural background, religious belief, and societal view. So, there are several definitions in the literature. The one that I do quite like is Johnson et al. By Johnson et al. 2006. A verbal or physical act of an explicit or perceived sexual nature, which is unacceptable. So that's important, unacceptable within the societal context in which it is carried out. Okay, so there's lots of content in there, but I think that is probably the definition that I find quite helpful. Okay, so in terms of epidemiology, how common is this? So the prevalence, depending on what literature you look at, can vary from 1.8 to 25. That's a huge range, right? And why such huge variation? For multiple reasons. Maybe they're looking at different dementia types and severity, maybe different study settings. So looking at ISP in the community versus nursing home. Maybe method of observation. So did they watch directly, or was it more kind of like reported by the caregiver or partner or chart review? And how long was it observed for? So was for just a day, weeks, or months? And different definition, as I mentioned, used for ISB. So there are lots of challenges in research area in ISB for sure. So as I mentioned, oh no, I didn't mention this yet, but ISV is more common in men than women. So what that means is that nearly all the studies, case studies, anything that to do with the treatments and intervention have been done in male patients. So how do we translate that when we have a female patient with ISP, which I for sure see in nursing home settings? And patients with more severe cognitive impairment are at higher risk of ISP. Physical expression of inappropriate sexual behavior like grabbing, kissing, hugging, that is more common in males, and more verbal ones are more common in female population. More prevalence in vascular dementia, but this is a controversial information, and more prevalence in long-term care compared to community sample. And it's probably true that the prevalence of ISP is underreported by family member because they might be feeling embarrassed to report this information to the physicians. All right. So I'm sure you are very familiar with BPSD, and BPSD, there are many different types. So similar, so ISB, inappropriate sexual behavior, is one of many BPSD, right? And within ISB, you can also categorize them even further. So this is one of the ways I want to show you. So sex talk is just when the person is just talking about it like, oh, you're so beautiful, come here, that kind of thing. That's the sexual verbal stuff, which is the most common form of ISB. And sexual act is a behavior, the act, the physical act. So touching, grabbing, exposing, or masturbating in a public place and private places. But there are also implied ones. These are more subtle ones, like openly reading pornographic stuff in the common area in the dining room or in the near nursing station, or requesting unnecessary genital care. That is actually quite common too in a nursing home. So these are different ways of categorizing ISB. Little bit different here. The next one is that intimacy seeking versus disinhibited behavior. So intimacy seeking is those are normal behavior that are misplaced in social context. So for example, kissing and hugging your own partner at home is very normal behavior. But if this person does that to other co-resident or caregiver, the staff at the nursing home, then that's inappropriate, right? So it's more of the setting and the person they're targeting. So that's intimacy seeking behavior. Disinhibited behavior, these are rude, intrusive behavior that's considered in almost all the context, okay? So fondling and exhibitionism. So in my clinical setting, my brain usually try to combine these two tables together. So I try to think, okay, is that intimacy seeking, disinhibited, and then is that physical, is that verbal, is that like direct, very, in your face kind of behavior, or is it more implied behavior, okay? So that's why I'm showing you those two tables, because I think we can kind of combine and use both those informations together. All right. So moving on to etiology of ISB, I think it's important to understand some of the etiology because some of the treatment is really targeting what we know about ISB etiology. So I'm going to talk about from neurobiology. I'm going to mainly go through 4 brain systems that has widely studied. Neuroendocrine factor, just briefly, clinical syndrome and psychiatric condition, medications, and psychosocial issues. So etiology, the first one, neurobiological factors. So we know that there are many CNS disease that has the symptoms of inappropriate sexual behavior, including dementia, stroke, post-surgery, tumor, head trauma, and so on. So when we look at the first the brain structure, I think this is probably the easiest one to understand. So think of a frontal lobe. You mentioned about me having a teenager boy. So we always talk about frontal brain. It's not fully developed in my children, and they tell me that as their defense, right? And I tell it's that brain part that developed later in your life, and it is those area where that for higher function of your brain. So executive function, the planning, prioritizing, like logical thinking, or also being able to stop yourself when you're about to say something that's inappropriate, right? So that more complex, higher function. And we know that frontal lobe dysfunction is often seen in dementia population, but it's also seen in bipolar and multiple sclerosis and brain tumors. So this is more disinhibited behavior. So the second structure or the brain area that I want to talk about is temporal limbic system. It's not just one part of the brain, but it's a combination of a different structure, including thalamus, hippocampus, amygdala, and hypothalamus. So the main function of this brain system is memory, emotion, and behavior. And the dysfunction in temporal limbic system can lead to hypersexual behavior, as we see in Kluver-Bucy syndrome, temporal lobe stroke, and epilepsy. So some of these conditions I'm talking about, these are not geriatric specific, but all these studies are done, with the younger population to understand the nature of hypersexuality. So that's why I'm mentioning some of these syndromes that, we don't see in geriatric population. So the next structure that the circuit I want to talk about is corticostriatal circuit. So a striatum is again the collection of a brain structure. It is very important in balancing the motivation with behavior and movement. So the dysfunction in this corticostriatal circuit can lead to more repetitive, obsessive, compulsive sexual behavior. And we see that in Huntington's, Wilson, or Tourette syndrome, to name a few. So the last brain structure is hypothalamus. You guys probably know the hormones, things that we talk about, endocrine system. So hypothalamus is a big control system for your hormones, and it has a direct effect into pituitary glands. So the dysfunction in hypothalamus can lead to increased sexual drive, manic symptoms, and so on. So those are a very quick review of 4 brain structures that we talk about in inappropriate sexual behavior. This slide, I'm not going to go in detail, but the key point here is that there are many hormones that have studied for inappropriate sexual behavior and also neurotransmitters. And why is that important? Because many of the treatments will actually target some of these. Okay. So the next one is clinical syndrome. And this is one of my key message. So when you see someone with inappropriate sexual behavior, please rule out delirium. I'm probably speaking to those of you who do this all the time, but please rule out delirium, any change in behavior of any etiology. Okay, so it could be medication, it could be infection. Pay attention to any anticholinergic medication, dopaminergic medication, any substance, alcohol, drug, and benzodiazepine. It could also happen in post-ictal patient too. So me being a psychiatrist, I of course want to talk about a little bit about psychiatric conditions. So the classic one that you can think about is like hypomanic symptom and manic symptoms, right? But we can also see inappropriate sexual behavior in psychotic patients as well. So I talked already a little bit about medication and substance. So I want to say psychostimulants, alcohol, benzodiazepine. So benzodiazepine, again, you guys know this already probably, but there's a paradoxical effect of benzodiazepine. So when you give this medication, they might actually be even more disinhibited and more inappropriate sexual behavior. So I just want to mention those. Another one that's really important to remember is all the anti-Parkinsonian drugs that increase dopamine, so dopamine agonist. So what dopamine agonist does is that it decreases prolactin, in turn increase testosterone and increase hypersexual behavior. And it's one of the study, the Close et al. 2005, have shown that about 90% of patients who are on dopamine agonist treatment had inappropriate sexual behavior. So just to show that, we need to think about maybe the dopaminergic medication is contributing. So the last etiology is a psychosocial factor. So again, we have to think about premorbid pattern of sexual activity and interest, maybe not having partner or maybe not having privacy. It triggers inappropriate sexual behavior, misinterpretation of cues. So in a nursing home, one might say and go, Mr. So-and-so, it's time to go to sleep. Sometimes they think that that's invitation to go to sleep, as in like have a sexual activity together. So sometimes that cueing, miscueing can happen. Misinterpretation of someone else as a usual partner, believing that one of the other co-resident is their own partner, and under stimulating or unfamiliar environment can trigger inappropriate sexual behavior as well. So in terms of history taking, it's very extensive. So I'm going to just leave it here for you to kind of take a look. But what is the point of doing this? The aim for our history taking is to uncover evidence of a psychiatric disorder, attention-seeking behavior, or long-standing hypersexual tendency, and also to look at specific precipitants. So is there any environmental or emotional trigger, misinterpretation, or medication? Or sometimes it could be something completely non-sexual. So maybe the person is disrobing because they're hot, or they need to go to bathroom, right? So uncovering all these precipitating factor is very important part of history taking. This is a really beautiful paper by Joller et al. 2013, giving you some extra things to ask. So what form does the behavior take? We talked about physical versus verbal and so on. In what context? Is it only during the bathing and shower, or is that also in any time of the day, right? How frequent is it? So is that just once a day? And sometimes I see those consults, it just happened once, and that was it, isolated incident. I wouldn't be as worried about that case compared to those cases where this person is engaging in inappropriate sexual behavior like several times a day, right? And what factor contributes? So we talked about the precipitating factor. Is it a problem? And for whom? And you might say, what do you mean by that? Of course, it's a problem. Well, it depends, really. So sometimes it might be a problem for the partner, or maybe a problem for the staff who are so distressed by it, but maybe not so much for the patient. So let's have an example of this lovely man and the man and woman, older person holding hands, okay, and just walking around in a nursing home, and that's about it, okay? And their own partners are completely fine with that. So then you have to ask, if I get the consultation inappropriate sexual behavior, they're holding hands and walking around, then I have to ask myself, is that a problem? And is that a problem for whom? Because sometimes, as a healthcare provider, we might be more distressed and not feeling good about it. But then when you look at the situation, maybe it's not as big of a problem, okay? But then there are cases where this person's, grabbing everyone, including co-resident. Of course, that's a big problem now, right? For almost everyone involved. And what are the risks involved? So to whom, and are the participants capable? And that's the tricky part. Sometimes I get involved in a case like the nursing home. Again, these are extra questions you can ask. So patient's awareness of the relationship. Is the patient aware of who's initiating sexual act versus, are they aware or are they completely unaware? Is there any delusion or misidentification affecting the patient's choice? Can the patient say no? If they don't want to be engaged in this behavior, are they able to say no? And that's a really big thing to ask. Sometimes you can't get a direct answer, of course, but you have to kind of explore around that. So there are many different ways to measure behavior. So I'm not going to talk about the first two. You guys are probably very familiar with the CMAI and an MPI, but there's one particular one for inappropriate sexual behavior, and it's out of UK called the St. Andrews Sexual Behavior Assessment, or SASPA. So it actually is it's a continuous direct observation of 4 categories of ISB, each with a 4 level of severity. I'm going to just pause. Is it really 12:38 right now? Oh, wow. Okay. So I'm going to speed up. I think we started a little bit late, right? So can you give me some bonus time, please? Thank you. Yeah. So I'm going to show you, this is the color print of the thing. So the first page, you're going to see different types of behavior, some precipitating factors, and the consequences from like just boundary setting to restraint, right? So it could be go somewhere in between. And this is very similar to DOS that you guys do. So just recording the date, time, and the type of behavior. So in terms of management, there are not many studies done. It's unclear what medication we should be using and in what order we should be using. So quite challenging for sure. So generalizability of the existing literature is questionable. But I do have to say this is one of the most common reason why I get consulted in nursing home these days. Sometimes I go in, half of my list is inappropriate sexual behavior with this person and that person, and I see both of them that day. So yeah, it's quite common. So management approach is actually very similar to any BPSD. So we should be using sequential approach, discontinue medication that worsens this disinhibition, rule out delirium, right? Like I talked about that. And you must select a very clear target symptom. And also it is a big multidisciplinary management, right? So this is not just done by only medication or just by BSO, but it's really a team approach. So non-pharmacological management, so we sometimes address environmental factors such as making sure that it's not too overstimulating or understimulating, behavior approach such as redirection or communication tools or interpreters. Some studies have found that helpful, referring to our services, to geriatric outreach team, or if you have a BSO embedded already, then, referring to BSO team would be a great idea. And sometimes we use alternative clothing. I don't know if you know what I mean by dignity suit. So it doesn't have any buttons or zipper in front to hide the cues so that it's harder to undress them. Psychoeducation is, of course, very important. And also at the organizational level, supporting the staff with the ongoing support and education is the key. So this is just a fun fact or the study that I found. So it's a study from 2008 where they had a case study of 68-year-old with a very complex history of dementia. Medications didn't really work, tried antipsychotic and so on. And at the end, they introduced a 3-foot tall stuffed doll, the Pink Panther. And it provided alternative means of a sexual release and became less intrusive to staff. So sometimes the creativity will really save you. So pharmacological medication, the management, it's all off-label, and I'm going to start with that, okay? So we don't have good evidence on these medications. We don't have a guideline. So we were very excited about the BPSD guideline that just came out from Canadian Coalition of Seniors Mental Health. But in regard to ISB, no recommendation, okay? So again, we are at a very early stage. But it's really important that you do communicate with the patient and the POA about what medication you're using and for what reason. Before I go into all the medications, I do want to say great review paper by Kindred Frank. This is a Canadian paper. So I just want to tell you that this will be a great place to start if you want to review all the medication options that have been shown some benefit. So these are the list of medication. You might be surprised, wow, there are lots of them, right? So we do have some options for sure. And I'm going to go through them by different types, category, and I'm going to give you some summary table. So antidepressants. So we know many antidepressant drugs are known to provoke sexual dysfunction and help with obsessional behavior. And it may also help with the additional symptoms that we see in dementia, like agitation, anxiety, and so on. So SSRIs are usually recommended as a first-line medication treatment for perceived safety. So I have some examples here. So these are mostly case studies again, but paroxetine, some data, citalopram, mirtazapine, trazodone, clomipramine is probably the only TCA, but we don't often use it because of the side effect profile. So yeah, some of these medications, they're not used by itself, but maybe combined with the antipsychotic medications and so on. So here is the pretty table that I provide to you from multiple studies that I've read. The one key thing I do want to tell you is that there are many potential side effects, so you have to be careful about that. The other thing is that this dosage dosage. Don't take it like the recommendation guideline. It's not a guideline. These are the dosage that was studied in these case studies. Okay, so I'm just showing you the dosage range that have shown some effectiveness, either partial or full. Moving on to anticonvulsants and mood stabilizers. So something like gabapentin and carbamazepine, I mean, we have seen that some of those side effects are decreasing libido. So I think that it makes sense that in some patients that is helpful. Lithium is usually not the first thing that I would think about unless this person already has bipolar disorder. And this study that have talked about the benefit of a lithium and olanzapine, this patient actually had bipolar history and also dementia. But this category is, again, known for many different side effects. So you have to be quite careful about which if you're choosing one of these medications, you have to be very careful about checking for side effects. Antipsychotics. So this is probably the medications that you guys see quite often when you refer someone for ISB. Again, not because we have amazing data and evidence, but it's because clinically that we have seen some benefit. And there are actually several case reports that have looked at Abilify, quetiapine, risperidone, and Haldol. The biggest study is actually is in Su et al. 2016. So it's the largest study so far. They've looked at risperidone and haloperidol for patients in nursing home setting, over 100 patients, and they've seen some benefit from risperidone and also haloperidol. But look at the dosage; it's a tiny dose it's not a big dose that we are talking about. So again, I give you the list of antipsychotics that have been shown some benefit, but I do want to say that you probably know this already, but according to Health Canada, there's a risk of increased risk of sudden death and stroke when you use any antipsychotic medication in dementia population. So that's the important piece to communicate before you get consent. Cholinesterase inhibitor is a tricky one. So there's a case study showing that rivastigmine can help ISB. And there's some studies showing that actually, no, it's the opposite. So donepezil actually making things worse. And you might have seen geriatric psychiatrists come in for the consultation and they recommend stopping cholinesterase inhibitor because sometimes those BPST, any BPST can get worse. So that's the reasoning. So the last part is the hormonal things. So I have to say, I don't use these medications often. And those times that I've used, I don't always have good outcome either. But it's one of the options and usually your last option. So there are several anti-androgen medications. So medroxyprogesterone acetate is a synthetic progestin that actually reduce LH and FSH right at the pituitary gland. And there's a cyproterone acetate, which is a synthetic progestin anti-androgen that doesn't work at the pituitary gland, but it blocks the receptor at the receptor level. So those medication, theoretically makes really good sense. The next one might surprise you. Finasteride, 5-alpha reductase inhibitor. You guys probably know that as a BPH medication. Yeah. So it actually had anti-androgen effect as well. So it inhibits the conversion of testosterone to active dihydrotestosterone. So sometimes we use that medication. But there are other medications that you might never thought of as anti-androgen medication, like cimetidine, which is antihistamine, antifungal medications, spironolactone, and some beta blockers even. So there are some, other options that we can use. The next category of hormonal agent is estrogen. So sometimes we can use a synthetic estrogen to decrease testosterone and libido. And this one study I'm telling you here had really good success of using estrogen in patients who did not respond to SSRI. Lupron is a very expensive drug. It's an injectable medication. It's a gonadotropin-releasing hormone analog, subsequently decrease LH-FSH and decrease libido. Very expensive drug, as I mentioned, and only one case report, but makes sense. So again, here's the summary table for you for your own learning. So I'm going to go that quickly. So the practical approach is that there's no specific guideline to help with which medication you should use first. Only use medication if you failed with a non-pharmacological approach, so behavior approach. So the general consensus is that maybe use antidepressant first, like SSRI. Citalopram is the one that I've studied the most so far. But if there's a more urgent need, let's say the patient is psychotic, there's a safety issue, we need to get it done quickly, then I'll usually recommend antipsychotic medication. Hormonal treatment should be saved as a last option and avoid use of a benzodiazepine. What are the impacts on patient and caregiver? Of course, patient might feel embarrassed, they might be anxious, but it can have a caregiver impact on caregiver, and I'm including healthcare workers too. So staff who work at a nursing home, retirement home, who have been exposed to inappropriate sexual behavior, the impact on them, psychological impact on them. There may be a legal and safety issue, and the caregiver may experience distress, frustration, and embarrassment, and there's definitely the risk of burnout due to the stress they experience too. So the psychoeducation, the education around ISB is really important for patient, caregiver, and healthcare provider. So take-home points. So sexuality, hopefully I convinced you that sexuality in older people is an important topic. And our own bias, our own belief system might impact how we care for them, how we treat them. ISB is a type of PTSD and largely understudied and under-recognized. In terms of management, we don't have much evidence, so we try to go with behavior approach first. And then if we need to use medication, start with SSRI, unless there are other reasons like safety issue where you need to use antipsychotic medication more quickly. But there are many different options, but lack of evidence. Psychoeducation for all of us is really important, but also for family members. So with that, 12:49, and I'm going to stop there, and I'd be happy to take some questions.
Thank you very much, Dr. Chun. I'll open up to questions in the room. We do have a microphone, so everyone online can hear the questions as well. And if you're online, please pop your questions into the chat, and then we can read them out to the room here as well. Any questions in the room? Check online. I know there's a couple questions that if the PowerPoint presentation will be available, there'll be a recording posted eventually. We're just updating our website as well. So in due time, please bear with us.
Hello. Thank you so much. That was wonderful talk. Much appreciated. You mentioned that almost half your consults in long-term care were related to ISB. What's your experience sort of anecdotally? Are the majority able to be managed through non-pharmacological strategies, or what sort of your average there?
Yeah, I think that by the time it gets to me, I think the team have done a wonderful job. So I can't really tell you what percentage of those cases actually didn't reach me, right? Because by the time I go there, BSO team embedded at the nursing home already have done some stuff, and our outreach nurse, who's also BSO, have worked on some of the stuff. So I don't know like what percentage would be the successful approach, right? But the ones who, by the time I have to see them, the medication has never been a perfect solution. And that's the key message too, that even if I prescribe multiple medication, like try this and try that, the behavior approach, it must continue. And sometimes I think people are feeling very distressed and anxious and looking for the quick solution to that. But I have to say, ISB is one of the most challenging things that I am dealing with it in a nursing home setting. And sometimes it takes time. Like, as we know, like SSRI can take 6 to 8 weeks for the effect, right? So some of these cases, you just have to wait and see whether those medications work. So I don't know if I answered your question, but yeah, I added a little bit of extra things there. Yeah.
Thank you.
Yeah.
And then in terms of education for care staff, I know of the Behavior Supports Ontario on their Brain Exchange website. They've recently released a learning
Yes.
module.
Yeah.
I know I've recommended to my staff to take.
Yeah.
Are there other education modules?
I think of the currently in the regionally, I think the BSO website is the best one. I think that's what biggest resources that we should be using. Out of rural Ottawa, we also have the toolkits that we provided to each nursing home. It's a big binder with lots of resources. So some of those things can be referred to as well. And just in terms of if anyone's looking for education like videos, UCLA actually has lots of YouTube videos on how to address BPSD, including ISV, in a nursing home or in the community setting. And I use that quite a lot for like a medical student teaching. I didn't include it here because you guys are like experts, but UCLA website, YouTube, lots of YouTube videos available publicly.
Thank you.
Yeah.
It's a very nice topic. As a nurse, I've been experiencing so many things. And for this, I kind of feel so many things kind of inhibit the nature.
Yeah.
Is that right? So in all the nursing home, have you had something encourage this behavior? For example, give a private room.
Yeah.
And give them time.
Yeah.
Choose my
Yeah, for sure. So I think that's a really good point because sometimes it's not about medications. And sometimes, like you said, it's not really a big issue, big problem. Again, I'm not trying to downplay, but sometimes we have to ask ourselves, is there really a big issue where we need to give medication? And sometimes they get mad at me because I say, I don't think there's a role for medication for this patient, but please continue to work with BSO for behavior approach. And sometimes, we might say things like, if the grown-up adult wants to watch pornographic materials in their private room, right? Then is that a problem?
is have the private.
Yeah. So some patients have a privacy like in a private room and some patients don't. And that's where, masturbating in their own time, in own room, it's their right, right? But if they're doing it in a dining room or in a common room, that is a problem, right? So because so some of these things that we could use in someone's house, we cannot really utilize it because they're in a nursing home setting. Yeah. So that limits how much that limits what we can use in terms of behavior approach. Yeah.
Just my thought, it would be nice if they provide.
Yeah. Yeah.
Would be nice.
Yeah. To release that need. Yeah. Yeah. Thank you.
Any other questions? Also encourage you, those of people who are online, please submit your questions via the chat and we can read them out.
In your experience, when there's staff involved or other residents involved, how often are the police called and charges are pressed? Do you see that?
Charging, no, but there is the policies that nursing home has to, according to Ministry of Health long-term care policy. So when there is an inappropriate sexual behavior, they do have to follow appropriate step. So many cases, the police is already contacted, POAs are already contacted. I haven't seen a cases where one of them is charged, but those aspects are already done. And us getting involved is also one of those doing the due diligence. So the police is aware, POA aware, physician is aware within the group, but they're also making sure that we come in and provide any additional resources or recommendation to minimize the risk again. Yeah.
Excellent. Well, there's no question, just kudos in the chat, which is great. I wonder if I could ask, you touched on this a little bit about consent, and I wonder how that interacts with capacity and how you handle that with dementia populations.
Yeah, so I think the capacity of the patient who's initiating the act and or the capacity of the patient who's on the receiving maybe about or more of the passive person in that role, we have to assess the capacity for both of them. So it's not just about the one-sided thing, right? It is dyad of the dynamic. So we have to make sure that they're capable individually, and also individually are they able to give consent. So being capable in one thing doesn't mean that you're capable for many different things, right? So even if the person is capable making decision about antibiotic, right, for UTI, doesn't mean that this person is capable to make to have sexual behavior with another person. So that's an important part. And the consent, again, are they able to provide consent and also understand the consent? And do they know that they can actually say no, even if they consented at some point, right? Are they able to say no when they feel that it's not appropriate anymore? So it's a very complex concept. And sometimes that becomes an issue more so if one of them is capable and the other one is not. And that sometimes can get into more legal situation. Yeah.
Last call for question. Well, Dr. Chen, thank you very much for your talk and giving us a piece of your day today and sharing this great information. I will just mention, so we're going to pause the rounds for the summer and we will return on September 17th to talk about medical holds with Brady Hamilton. So please join us again here in person and online on September 17th. And I'd also like to thank the RGPO education panel for helping us put on these rounds and help find speakers. And we do like to make these as inclusive and impactful as possible. So if you do have suggestions for presentations or speakers that you'd like to hear, please send me an email or visit our website and drop something on the comment section, and we can incorporate that into future rounds. So with that, I want to thank you all for attending, and we'll see you back in the fall.
Thank you.